is Deborah Culbreth. I am a CLS student at Winston-Salem State University. I am also a medical lab technician in transfusion service at Cateford Valley Medical Center. The purpose of my study today is to determine if it is beneficial and cost-effective for the Blood Donor Center of Cape Fear Valley Health System to begin screening all female plasma donors with a pregnancy history for HLA Class 1 and Class 2 antibodies. HLA Class 1 and 2 antibodies have been reported to be a cause for TRALI, which is transfusion-related acute lung injury. TRALI is an acute immunogenic transfusion reaction that is the leading cause of transfusion reaction mortality reported to the FDA in the United States as well as worldwide. There is an estimated TRALI occurrence of 1 in 1,300 to 1 in 5,000 transfusions, with more than 20 cases per year between the years of 2003 and 2006. In 2006, there were 35 reported fatal cases of TRALI, with 22 being associated with the transfusion of plasma. Data obtained from the Retrovirus Epidemiology Donor Study 2, or REDS-2 program in 2007 determined that approximately 38% of all apheresis donors are females. I myself am an apheresis donor with a pregnancy history. I donate platelets at least every 2 weeks. With my pregnancy history, that means that my donor center cannot use my plasma. In this study, I will collect and compare prices from Wisconsin Blood Centers, Florida Blood Centers, and the American Red Cross for the screening of HLA Class 1 and 2 antibodies. I will also determine if HLA antibody screening is beneficial by determining the loss associated with the disposal of plasma from female donors with a pregnancy history. Some of the literature that I reviewed includes a study performed by Triozzi, the effect of previous pregnancy and transfusion HLA alloimmunized in blood donors. Implications for a transfusion-related acute lung injury risk reduction strategy. The AABB made it where blood donor centers had to develop a TRALI risk reduction strategy. At our facility, we just only take plasma from male donors. We don't use plasma from female donors with a pregnancy history. We do use plasma from females without a pregnancy history. Like my plasma would be discarded after donation. It was discovered by REDS-2 program that approximately 38% of all apheresis donors are females. Therefore, utilizing the TRALI risk reduction strategy of only using plasma components donated by male donors could result in an incredible loss of apheresis platelet donors. TRALI can also be caused by the transfusion of platelets. It's more commonly associated with the transfusion of plasma, but it has been known to be caused by platelet transfusions. Another study performed by Powers, testing only donors with a prior history of pregnancy or transfusion, is a logical and cost-effective transfusion-related acute lung injury prevention status. It's similar to the one proposed here, whereas Powers' study looked at 3,586 volunteer donors. 1,600 were females, 1,980 were males. the females were asked how many times they had been pregnant and how many years had passed since pregnancy. All donors were also asked if they had ever received a blood transfusion. There were some invalid screening results. So 1,009 female donors were used in the study. The time since their last pregnancy ranged from 6 weeks to 45 years. There proved to be a correlation between pregnancy history as well as parity and HLA alloimmunization. Of the 1,009 female donors, 256 tested positive when screened for HLA antibodies. 3 of the 25 transfused male donors tested positive. The study was broken down further to determine the results for each HLA class. Of the 259 donors who tested positive for HLA antibodies, 101 were positive for Class 1 and 64 were positive for Class 2. 94 tested positive for both Classes 1 and 2. There were 27 positive HLA antibody results among the 459 female donors that stated they had never been pregnant, nor had they ever received a blood transfusion. I do have a chart, 2 charts here that break down the donors to females and males and how many have been pregnant, paragravida, invalid results, 7 incomplete pregnancy data, so they were, those results were not used. In this study, I will collect and compare the prices from Wisconsin blood centers, Florida blood centers, and American Red Cross for performing the HLA Class 1 and 2 antibody screening. I will also determine if it is beneficial to do the HLA antibody screening by determining the loss associated with the disposal of plasma from female donors with pregnancy history. So I will look at how many of our donors are females with a pregnancy history versus the total amount of our donors to determine if it's even beneficial for us to attempt to do this sort of risk reduction strategy. I have been with Transfusion Service of Cape Fear Valley Health Center for 6 years and have witnessed 1 trolley occurrence. We've had some TACO reactions, which is transfusion acquired circulatory overload, which resembles trolley. But I've only seen 1 case of trolley in the 6 years that I've been working here. But I do know that we destroy a lot of plasma because the patients are females with the pregnancy history and we only take male plasma. What I hope to find with this study is that it is beneficial and it is cost effective for us to send the plasma to a blood center to have the HLA testing done. I would like for us to be able to use someone like myself out my plasma, especially for AB patients, because AB plasma is used during traumas. It's also used for babies or anyone who we don't have a blood type for. We run really low on AB plasma. Usually only have about 15 to 20 on the shelf at any given time. So I would like to discover some way to boost our plasma supply. Maybe this could actually be one way, if it's not too expensive to send out for HLA screening. I could also determine that it would be too costly to have donors sent out for testing. If it is found to be cost effective and beneficial to screen these female donors, we could find that a large percentage of those donors at the Blood Donor Center are actually HLA negative and could serve as plasma donors. With that being said, our plasma inventory could greatly increase, especially among the group AB plasma, which is utilized, like I said, during trauma situations. If it is determined that screening such donors is not cost effective, we would definitely continue with the trolley risk reduction strategy that we have in place now, which is to only collect plasma from male donors. My acknowledgements. I would like to thank my husband and my coworkers for sticking by me and believing in me. I would like to thank my supervisors for being there for me and working with me. And I would also like to thank Miss T because she has helped me out a lot the past couple of years with school and a lot of other things that I've gone through in the past 3 years in the program. Thank you, ladies and gentlemen, and I really hope that you consider my research proposal as valid and necessary to increase the plasma inventory at my hospital. Thanks.